Welcome to everyone. Ross Clark, I'm a partner in Hempsons, joined by Justin Cumberledge, a partner, Robert McCartney, Senior Associate, and Bryn Morgan, a partner. Robert, Justin, and myself are sort of on the corporate side, Bryn's on property real estate side. And we're going to have probably a bit like a discussion. So that's probably a good way where we'll exchange our views. And we've been sort of going through the 10-year plan and trying to figure out what it's worth. What it's worth is probably a good analogy as well, and what it contains. What we'll focus on today is probably, and giving you a sort of context and background briefly, but then get into the important points about how the plan will affect core practice contracts, revenue streams, how it will affect PCNs, have a look at federations as well, and then Bryn will do a bit on the neighbourhood health centres and premises developments there. If you've got any questions, please add them to the chat. We will keep monitoring them and we can incorporate them into the discussion as we go along. So just to set some context then, there's lots, as you will all be aware, going on around the NHS. Funding constraints, lowest ever public satisfaction, waiting lists, ageing workforce, abolition of NHS England and the merger of ICBs. It seems like a crisis point, and actually the 10-year plan recognises that. It says the NHS now stands at an existential brink. The choice for the NHS is stark: reform or die. So it's sort of last chance saloon for getting things right. Now, the NHS and the health service has survived since the just after the war. So you can take that with a pinch of salt. It probably will be here, but there is a significant feeling that change is required. And the 10-year plan has three main focuses: sickness to prevention. Become more responsible for your own health and care. Analog to digital, which they snappily call bricks to clicks, but we'll focus on hospitals community because that's really the focal point here, and the new sort of neighbourhood health service as it's called in the area. Now, you've had a shrinking of the NHS England is disappearing. So you've got the Department of Health and Social Care and NHS regions being left to deal with the sort of overall strategy and direction. You've got commissioners, predominantly ICBs, integrated care boards, will be the commissioners, and service providers, be it acute and primary care, delivering high quality, effective care, but with a focus on shifting that care delivery into neighbourhood. And it's all around shifting from hospital into community. This is sort of an overview about how it looks. So you've got sort of three in the middle line there. You've got core primary care, you've got neighbourhood commission services and place-based commission services. So one fundamental change is there's going to be two new contracts. There's going to be a neighbourhood contract and a multi-neighbourhood providers contract. So really they're focusing on PCN level and sort of Fed level with these contracts. And we'll discuss those a bit more. But for core primary care, that's traditional practices. For the neighbourhood commission services contract, it'll be traditional practices and or PCNs. Probably the PCN is the focus there. And you will have a single neighbourhood provider. Now that probably will the PCN, but not necessarily. It could be a GP Fed could cover that role. And we'll discuss that in a bit more detail in the next section. And then at sort of your federation level, place-based commission services will be multi-neighbourhood providers. That should be the federations. But when you look at the very top of that, we've got commissioners and integrated health organisations. So why is that? Well, you've got commissioners, your ICBs, but the 10-year forward plan talks about giving an opportunity for the very best FTs, foundation trusts, to hold the whole health budget for a defined local population as an integrated health organisation. So you're looking at a foundation trust, and when they mean the very best, I think they mean that ones are in surplus and not in deficits, will hold and manage the whole health budget and become effectively commissioner and provider. Now, They also say that there'll be a small number of IHOs designated in 2026 to become operational by 2027. And they also say over time they will become the norm. So there's a bit of and we're going to look at opportunities and risks in a bit more detail, but that is something to just be aware of. You've potentially got a foundation trust acting as commissioner or responsible rather for a whole budget, and how they deal with that budget and how they carve it up and how they integrate and how they work with GPs, PCNs, federations is going to be interesting. And just bear in mind it is over time they will become the norm. So there's a risk there to federations and others, and also an opportunity as well. So that's the sort of broad overview and the background and the context. I'm just going to hand over now to Justin and Robert just to look at the possible effect we'll have on contract and income streams.
Thank you, Ross. And can I just briefly mention and bring Justin into this part of the conversation that a lot of this is based on modelling in other kind of countries and other environments. And so although we're seeing big changes, it is based on a kind of a model that has been quite well established around these neighbourhood concepts. Did you want to?
Yeah, well, I mean, some of them are in the 10-year plan. They talk about the one in South Korea and places like that. If you look at Spain, is actually has been for the last 10 years seeking to implement something similar to what is in the 10-year plan. They are looking at what the best is happening globally and then bringing it in. And one of the things in the 10-year plan that they do say that different models will work in different places. So it isn't exactly 1,000 blooms across the country, but yeah, they want some consistency, but they also have now got it that what works in one area isn't necessarily going to work in another. And sometimes that's going to be for geographical reasons, sometimes it's going to be about the population, it's sometimes just going to be the way that the NHS healthcare sector in a particular area has evolved with the different changes. So whereas we'll be talking in broad terms, don't necessarily think it means that what you've got and what is working is just going to be thrown out of the window. It isn't. If it's working for you and in your area, that should be realised and supported by the Commissioner.
And building off of that, for those of you who've been following the various kind of publications and podcasts and interviews with key people, one of the recurring messages that I think the GPC from the BMA are saying is they're hearing from the government that this is an opportunity, a starting point. I think the term is starter gun. So feedback, give your responses, could test models and see what works in your area. So there's, as much as we are kind of saying what's in the 10-year plan, where it actually states, we do feel all of this is going to be subject to variation. The extent to which the variation, that will be the big test.
Yeah, and also I just think, just very quickly, of all these models across the world, none of them is the perfect solution. So obviously if someone had found that, then we'd all be doing it. But interesting, just looking at Kinzig in Germany, what they have found is that by doing this, it has maintained the level of healthcare. And as Ross was saying at the beginning, there is a recognition that the NHS is actually failing to maintain the level of healthcare. So if this can buck that trend, that downward trend, then we are succeeding.
So in that context, looking at the actual kind of core contracts, and the majority of people on this call are individuals who are directly involved in practices. You have your PCNs and some of you also involved in federations. So there's this recurring question as to what exactly does this mean for your absolute core GMS, PMS, or even APMS agreements, contracts that are currently in place. And actually, the 10-year plan is relatively silent on it. It doesn't mention it in at all, which is some people are saying it's slightly concerning, but I think there's probably a justification for that, in that it is focusing very much on the scale and the building blocks of neighbourhood. So reading between the lines, what it actually leads us is traditional practice is the continuity option. It is where you will continue to run your GMS and PMS practices. You will continue, and we'll discuss a bit more detail about the role of the PCNs a bit later, but you'll continue to provide at scale and collaborative working within your PCN, and you will continue. Now, what that actually means in the long term really depends on the pressures, the push and pull factors that are actually applied within the system, because it makes it very clear that there will be encouragement to work at a neighbourhood level, and the term was that GPs should take a leadership role within new neighbourhood providers. What those neighbourhood providers are will again need to be further tested. On that point, so the next level of kind of option, the kind of alternative contract that will be published at some point, we're waiting for timeframes, is going to be designed for single neighbourhood providers, which cover a population of approximately 50,000 people. And it states that it will replace core contracts, so it's an alternative to them. When it says replace, we don't know whether or not that actually means you have to kind of terminate them, or it could be a system a bit like was published in, I think it was 2017, when they were doing the accountable care kind of options. Justin, do you want to expand that?
Yeah, so I mean, yeah, the 50,000 population, I think that's a figure we're all got quite used to, haven't we, with the PCNs? The question, so if you go into a single neighbourhood provider, the idea there is that, well, if you're already a single PCN, single practice PCN, you're getting quite near to a single neighbourhood provider, but only in respect of the GMS, GP type services. So the thing to remember with a neighbourhood provider is that it's multidisciplinary. So you've got to bring in the healthcare sector, the third sector, the secondary healthcare consultants, and they illustrate this through Whitstable, where they've got consultants coming in doing sessions, where they've got X-ray machines, where they've got the ambulance station, yeah, and all of that. So you can't just rebadge your PCN as a neighbourhood provider unless you've really thought about Schedule 7 in your network agreement, which of course had the concept of bringing in other members into your PCN. So if you've really done that, and I'm afraid we haven't seen many of those, then you might be only a very short step from becoming a single neighbourhood provider.
One of the things
could I just, there's a couple of questions come in on this. One in particular from Mo, would the core GMS PMS funding transfer to the IHO? And I think no is the answer to that. I don't think we're looking at that. It would be a neighbourhood budget, but where the transfer may take place is what we're discussing from the single neighbourhood provider. And Brian asked, would the single neighbourhood provider seem to encourage the sacrifice of core contracts? And the answer to that is possibly, if not yes. And as Justin said, we remember the MCP model, where initially you would, the GMS contract would terminate, but remember there was a backlash against that, and they said you could suspend your contract, try the new model, and then could pick it back up again if you didn't like it. So I just suspect they might do something like that in this case. You become a single neighbourhood provider, and they might offer that you could hang your GMS on a closed peg and suspend it and go back to it later. But that certainly, again, we don't have the detail, but that is something that is significant.
Of course, the reality of that from the theory is very different. You know, the reality of it is once you've undergone all the work that's required from a legal perspective of merging your services, your contracts, getting the correct, whether it's a partnership or incorporation of a company, gone through all of that work, your staffing restructure, your cultural changes, actually undoing all of that, if you suddenly think try before you buy didn't work out and we want to go back, is incredibly difficult. Incredibly difficult. So this will, we suspect that this model will probably be appealing, subject to what the actually gets published in the terms of the offer when we finally see the final terms of it, for those who are already operating a single PCN practice at or around the 50,000 kind of population basis. For everybody else, it is going to be a real question as to whether or not you are ready and in a position to have a serious discussions about merging, because in reality that's what it's going to involve, to cover those types of services. And only your PCN, and possibly even your neighbouring PCN, if you're not big enough, will know the answer as to whether or not that's possible.
So, yeah, and somebody's just asked, well, we're 100,000 in our PCN. Again, going back to what we were saying earlier, if what you're doing is working, and if you can become multidisciplinary and involve other sectors, primary healthcare sectors within your PCN, then they're not going to suddenly say you've got to divide into two to fit into what they're saying. We just can't see that. There's no point destroying something that's working. I think with the IHO, we have to remember that you say, well, will this be the end of a core contract? No, if it's working. But where we're seeing failing practices, they will encourage other contractors to come in other guises. So that might well be a single neighbourhood provider. It might be, as we'll come on to, a multi-neighbourhood provider, come in and take over those practices, just as we've seen some GP federations do it, just as we've seen some FTs do it, and as we've also seen some sort of chains, if you like, or come in and acquire practices, and particularly, of course, the targeted ones or the failing ones. So, yeah, if you're a failing practice, this isn't going to be a safety net by any means.
Well, that feeds in nicely to say to the next level up of multi-neighbourhood provider. So this 250,000 population, place-based size entity. Now, we will discuss this in more detail a little bit later, but fundamentally, it's got two different roles, as explained in the plan. One role is actually to hold a whole range of functions that currently sit with the ICBs. So they produced a model ICB blueprint a month or maybe 2 months ago now, which refer to a whole range of services that ICBs will no longer be providing. And they just said, going to the providers. Now, that's fine for foundation trusts and NHS trusts and very large entities. Didn't necessarily make sense where that would fit in the context of general practice, as individual practices will not be taking on mass placed and system-wide support services. But this is where the multi-neighbourhood provider then fits in. And the second wing of that is large-scale services that can be provided across this population, and potentially including running GP practices where they're failing, which, as Justin's already said, we have seen to varying degrees of success. I guess that, again, one of the key questions will be to what extent is there incentivization to make that a more appealing option for practices rather than an emergency exit type situation, which a large number of them currently are.
I think with the multi-neighbourhood provider, we're going to have to see who is going to be taking this up. But from a GP perspective, and the federations, if you're already formed, if you're already working together well, you have definitely got an advantage here because you have got the foundations. What we have to also remember is that already the legislation is in place for FTs to fulfill this role. So that came out in the 2022 Act, and it hasn't actually been commenced. but they're only going to lay something in the library of the House of Commons for a few days, and then it will commence. So the legislation is there for FTs to take this role.
So taking this back to kind of where we started with this slide, the starting point is continuity, no real change unless your area either wants to change or there's suitable incentives to do so. And we've said in this slide, looking at revenue streams, and that might be where the carrot and stick is applied to this. It referenced in the plan that either at single neighbourhood provider level or at multi-neighbourhood provider level, and that's, at some point, I'm sure we'll find a better shorthand for these names. But at either of those levels, they will be undertaking enhanced services. Now, enhanced services generally, for every practice is different, can account for approximately 40% of the revenue of a standard practice. If that is not guaranteed at traditional practice level and has to be provided at a single neighbourhood provider level, for example, or potentially at a higher, even bigger scale across the multi kind of level, then that is a massive risk to practices who are not fully engaged and are not secured that they will be receiving that funding. And we only need to look at the vaccination programs, the Schedule 8, the network agreement for PCNs, to see that there is that shift already. So there is an encouragement to run flu programs at neighbourhood level. And various areas have either adopted it or have chosen not to. If this suddenly becomes compulsory, that's a very powerful stick that is going to force changes. If, however, it becomes optional and it's beneficial to practices because actually you can run it more efficiently, it's a very nice carrot to influence change. And I think we'll really need to see the detail of this to know to what extent practices are at risk from the revenue changes.
Yeah, and also to what extent FTs are going to benefit from them as well if they can participate in primary healthcare, because there is this push and pull, and they're trying to reduce the amount of activity in especially accident and emergency access, and have that undertaken by primary care. And if that happens, then there's rewards for the efficiency, and the FTs will want to share in those rewards. Yeah. So that'd be another push and pull, carrot and stick, as you say.
And I think that'll really define the success of these changes, fundamentally.
Yeah.
So moving to the next slide about risks and opportunities, which again builds off the revenue. We've said there is clearly risk here for the revenue, but there is also an opportunity in that one of the biggest suggested changes that actually is in here about foundation trusts, or all trusts, to be honest, but all trusts are expected to become foundation trusts. That's a topic for another team, but it's an interesting one. All trusts will be losing, in theory, their bulk contracts, and they will be broken out into specific service contracts, with a view that they can then be reviewed to say what can come out into the community in a properly funded manner. I've certainly worked on projects in the past where this has been attempted, but the overlapping costs and almost unintended consequences on the trust meant that the level of change was limited. If they really push through with this, then actually there could be huge changes, because there's large suites of services that could be moved. Who could pick up that work? Either the neighbourhood provider team, subcontracting down to practices, or potentially the multi-neighbourhood provider. And both then could be properly funded, that's the key question, services that practices could pick up and be key parties to provide, much as we see in some of the APP type contracts like ophthalmology and cataracts, etc. So there's certainly a risk but an opportunity in relation to revenue. huge amount of this then really pivots on the amount of influence that primary care and general practice specifically is going to have. As I'm sure anybody's listening can tell, our view is you've got to be in it to win it. You've got to be fully engaged with your system and your and the changes to know what's going to happen. Because if you don't, you might find that not only are you potentially losing your revenue streams, but you don't necessarily what's happening in terms of the changes in your own neighbourhood. There could be contracts that go out to foundation trusts who are then changing services, and suddenly things are being changed around you that makes your life a lot harder.
But really worth knowing that and seeing that in the 10-year plan, there is this underlying theme. The primary care is much of the solution of the NHS's present ills. So what primary healthcare is saying in its unified voice within its area must be listened to, because if you're coming up with solutions and ways of doing things which will be impactful on your area, then that is what they want to hear, and that is what they should be investing resources into. So the door is open, and the opportunities are very much there, but you do have to speak in a unified voice. And again, this is where those who have managed to keep their GP federations going through the recent difficult times, and will have the benefit, because you'll have that unified voice with all of you being members of the GP federation.
And then that allows you to start shaping these new services.
Exactly, and suggesting new services.
Yeah,
these are things we will do. This is the impact we think it will have. So many people are presenting at A&E with this, or if there's a diabetes service and we've got a predominance of that, or you can run ophthalmology services in your health centres and so on. Then that is going to be impactful.
Well, if we kind of think through what would this look like if it really works out and it's really beneficial to general practice, then it actually becomes grounds-based, neighbourhood-based commissioning of services. That the powers that be, as it were, are saying, that's great, here's the funding. Yeah. As long as you're delivering the quality and standard and it's within the budget, then happy days. You end up in quite a powerful position. And that's that for everything you might see about the concerns about these changes. I think that's the dream scenario that people are working towards. And a key part of that, just touching on this final kind of tab, is innovation on this. And although we're not talking today about the digital solutions, there's a huge amount in there about alternative
genomics.
Genomics as a method of future healthcare prevention and prediction, opportunities for more research, opportunities for more IT systems. Huge amount of AI, the concept of the doctor in the pocket, which not quite too sure how that works, but there is a huge amount of opportunity there that hopefully will be funded. That's always a key hopeful word.
But also, again, so much about preventative care, so much about looking at we've had social prescribing for a long time now, but upping that and getting rewarded for doing that. And GPs, you're the ones who are in the best place to do it. Somebody meeting a consultant isn't going to be referred to going to the gym or something, but GPs are really in a very, very good place for that.
There were three other points of just very quickly, literally whistle-stop mentions here. First of all is Car Hill has been mentioned again and is being reviewed. We have no other detail. I don't think anybody else has any detail. it seems to have been reviewed since the day it was implemented. So things may or may not change with that. So, but just to be aware, that is an active part of the conversation in this. Another point to reference is there is a concept in there about patient power payments. It's not clear if this fully is going to be implemented for primary care or not. But the concept is that patients will start having a say over whether or not services get the full scope of payment. Now, if there is suddenly brought in this level of uncertainty as to what your actual budget is and to what the achievements are, that does create a huge amount of difficulty for your services. So the detail really needs to be published on that to be a clarification. Is that going to be applied to primary care or not? And what does it look like? And that's going to be started piloting in some trusts, I believe, next year, potentially at the end of this year, if they get that worked through. And then the final thing, just very briefly, is there's this concept of year of care payments, and the idea being that neighbourhoods, and certainly the multi-neighbourhood level, but potentially at neighbourhood level, will get entire budget controls or sums for patients that really need it. So if you've got a patient with long-term conditions, multiple issues, you'll see actually it's not just a an ad hoc response. It's actually put a budget that goes with their care plan. Again, the detail of that needs to be worked through, and the extent to which primary care will be involved in that is unclear. But a logical thing is, if this is about getting continuity of care, surely GPs have to be at the very heart of doing that as part of the care planning processes.
Yeah,
Robert, can I just interrupt?
Yeah.
There are lots of questions, really interesting questions. I'm trying to answer as many as possible. What we will do is we will try and put a sort of question and answer sheet together, which we can circulate, but two or three just brief ones. What happens if PCNs are less than 50,000? Would they need to merge? Well, not necessarily. There may be some leeway on that 50,000, as there has been to date. So that's one to watch. Could community trusts run these contracts? Yes, a community trust could well step in as a multi-neighbourhood provider. That's a possibility. And just make clear that the integrated health organisations would not necessarily be commissioners. They would be given a budget, and they would be operating the budget and the spend, which in a way is commissioning. I think I called it like commissioning, but the contract would ultimately be with the ICB, but they would be delegated authority to manage that budget across the whole healthcare patch. Robert, back to you.
I think in relation to the point about can community trusts run the contracts? Yes, multi-neighbourhood, potentially also at the neighbourhood level. I don't see any reason why they couldn't. One, we need to see what the actual contract looks like, but actually existing contract mechanisms would allow them to as well. If they were to take over a number of GP practices in any given area, either through APMS or through a contracted GMS model. There's various things that put some limitation on that, which is outside the scope of this, but it's possible they could already do that. So actually, yes, they could certainly take over those models.
But just going to Twan's point very quickly about what if your FT is failing, could it run an IHO? The answer is no, because the commissioner would not delegate the budget and responsibility to a failing FT. Yeah,
they've made that very clear. That could be the ultimate aspiration for trusts in the future. It's at least the way that they presented it. So it certainly won't be done quickly. Okay, so the next slide is quick questions about, do primary care networks have a future? We've kind of touched upon this already, and I think the answer, as we've helpfully put here, is yes, no, maybe. Certainly for the foreseeable immediate future, yes, there is no doubt about it. There's this period of continuity. PCNs are needed to ensure that there is that stability of integration of services, the collaboration of practices. They are still the building block at the moment where you've got multiple practices in any PCN area. Where their future becomes less clear is if you are going towards a single neighbourhood provider, and if you're already a single practice PCN, you don't need necessarily a PCN in the future. You would just have your new contract of whatever structure that would be. And I think where the biggest risk comes is in those areas where you do not have a functioning PCN, and certainly for practices who aren't in a PCN, you could find that your neighbourhood services are again being taken away from you and being provided by other entities who hold a neighbourhood provider contract or a multi-neighbourhood provider contract. And I think that's quite a significant risk. Now, I suspect that it'll take a while before the NHS is confident enough to take such a step, but that is foreseeable. You can see that happening.
Yeah, I think once you see the new contract come out, the new neighbourhood contract come out, you probably need to immediately start asking, now can we convert our PCN to that contract? Because if the neighbourhood contract is the future, then you've got to be part of that. And I suspect what it will mean is that you have then got to collaborate with various other health and care providers. And that would be the end of the PCN as you know it, but it would actually be a development of the PCN.
I do wonder when we talk about the new contract, we've been having these discussions as to what will the actual benefit of making that change be as opposed to holding your existing contract. And the massive unknown on this is what the outcome of the negotiations of the new GMS contracts are going to be. I mean, I think the projected date is that won't go live until April 2028. So, we've got a long time. There's going to be a lot of change in between. I suspect these new contracts
and change
want to be at the same time. Yeah, essentially, in terms of stability, the worst case scenario, that's for certain. But whether it's not getting to the politics. But yeah, certainly PCNs are here to stay for the time being. But you've got to make certain that they're working and they're functioning, otherwise they could lose out. So
the other thing, sorry, Robert, just before you
sure.
move on, I think also you need to think carefully if your PCN doesn't have an incorporated entity, if it's entering into contract and the contract's significant, and just for ease, rather than having individual contracts individual practices, or rather even individual partners signing on contracts, you need to think about whether you incorporate your PCN to have a company that can take the contract. Sorry, Robert, back to you.
Well, and potentially, again, we won't say for certain until we know the new contract, but potentially incorporates your actual practice level as well. At the moment, that's a very much hotly debated topic as to whether or not it's beneficial or not. The new contract may make it easier and more appealing, but we won't know that until that's been published. Federations then, will federations have a bigger role to play? The starting point on this is just to recognise that there are different scales of federation. If you're a relatively small federation that provides services to your practices and your PCN, maybe have a couple of smaller contracts that aren't at place level, you probably will continue as some form of provider, subcontract provider mechanism for your PCNs. You could potentially become a single neighbourhood provider, and that won't represent too much difference from where it probably currently sits. What we're really thinking here are those larger federations and potentially the confederations of, where they're coming together, which we have helped form several across the country now, that sit at the place level, at that multi-neighbourhood provider level. As we've indicated, the ICB model blueprint has a large number of functions that are support functions that are supposed to be moving at this scale. They include things such as shared backroom functions, digital transformation, overseeing the estate strategy, which I know Bryn will mention a little bit more on the next slide, data analytics and quality improvement functions. They're all mentioned in the 10-year plan. What's not mentioned in the plan, but is mentioned in the model blueprint, is actually services such as infection prevention and control. So currently, those support services that you receive from the from the ICB are going to be recommissioned or delivered elsewhere, potentially your federation could be the provider that provides, delivers that. Likewise, safeguarding, medicines optimization, and integrated working with SEND type services are all mentioned in the blueprint. So there's certainly these support functions. There's all sorts of complexities about VAT and how that's actually delivered. Again, slightly outside the scope here, but there's a lot of complex discussions that need to be had, just as there were back in 2019 when PCNs were delivered. And then you've got this other function of holding contracts at scale, which could be subcontracted down to individual neighbourhoods and practices, or could actually be delivered. And this is where the really ambitious federations that have got infrastructure could step in and provide this, which really would become a very powerful voice in the system for their localities. One of the things I just want to also add in relation to that is, if you don't have this, the alternative is most of those functions, especially the support functions, will have to come from somewhere, and the logical answer would be the local trust. And therefore, that gives them that foothold and incentive to start going towards the contractor and provider kind of scale. So definitely worth exploring, having those conversations. And we know we're inviting the conversations across the country at the moment at this level. Very much worth kind of expanding upon it and make certain you're involved and aware of it. So premises. Green, did you want to kind of lead on this part?
Yeah, sure. Hi everyone. So we're just going to focus a little bit now on the plan for new neighbourhood health centres, and whether this is going to lead to increase in premises development and in what fashion. So just looking at the plan, neighbourhood health centres are described as a one-stop shop in which patients can access a range of services from a multidisciplinary team for at least 12 hours a day and 6 days a week. And that potentially includes services from general practice, outpatient services, dental, community, social and voluntary sector services, so and possibly diagnostics as well. So I mean, they sound an awful lot like the old Darcy centres that we were, that Labour were obviously very interested in last time around. In terms of how many there are going to be, it's interesting. I was doing a talk in the autumn last year when Wes Streeting first started talking about neighbourhood health centres, and there was a kind of think tank report from the Institute for Public Policy Research, and in that document it talked about there being a neighbourhood health centre for every neighbourhood, and neighbourhood, of course, is we've been talking today. We're talking about 30 to 50,000 patients. Now, interestingly, in the 10-year plan, the word neighbourhood has been it's not a neighbourhood health centre for every neighbourhood, which you would thought would make sense. It's actually a neighbourhood health centre for every community, and it doesn't say what a community is. But if we look at some of the statements that Wes Streeting's made in Parliament, he's talked about there being 50 neighbourhood health centres by the end of the current Parliament in 2029, and 250 to 300 by 2035. Now, if you break that down, that roughly means one neighbourhood health centre for every 250,000 patients. So we're looking at, it's that multi neighbourhood level, provider level, as opposed to, say, what was the think tank report was looking at in terms of there being one for every neighbourhood, as it were. Obviously, the main reason for that must be cost, and I think the amount, the budget for building these things has been put at about £3 billion, whereas the think tank report was saying over 12 billion. So You can read into that whether it's to what extent this is policy driven or money driven, but there is the plan that we have in front of us is looking at one of these for that sort of population of 250,000 on average. Obviously, there'll be variations across the country. And what are they going to be? I mean, are these all new builds? Are they refurbs? Well, I mean, the answer seems to be from Wes Streeting's comments to Parliament is they're going to be a mixture. So we're probably going to see quite a few existing sites being rebadged, refurbished, and turned into neighbourhood health centres, and there will undoubtedly be new buildings built as well. And I think that the figures range from the low millions, presumably for those refurb jobs, to perhaps £20 million for a complete new build. So those are the sorts of figures that are being bandied around. Now, how's this going to be funded now and built? And this is where we've heard in quite a bit in the press recently about the public-private partnerships, kind of the looking again at those old kind of PFI models from years gone by. Now we know that that invitations have gone out to the market to come forward with proposals for this. We know that there are lawyers that have been instructed to look into kind of how that could be structured as well. But it does look as if that could be the avenue that the government is going down, and they've in doing so they're promising to learn from mistakes of the previous schemes, which have ended up being extremely expensive for the system. Bear in mind that you effectively you're getting private sector money, capital to build these sites, and then you pay it off over a lengthy contract duration, and some of those contracts were quite complex and have proved not to be the value for money that the system was seeking. So it will be very interesting over the next few months to see how that develops. What sort of structure are we going to see? Is it going to be similar to LIFT, which is obviously something that's been used in the last 20 years ago or so now? But then in terms of the kind of the occupiers of these sites, whether GP practices may be taking leases of neighbourhood health centres in future, we need to be thinking, well, what are the costs involved with this? And we're aware that there have been a lot of issues over the years concerning service charges, and these centres being quite expensive. So we really need to be looking at that detail and understanding what the costs of these centres will be, both in terms of building, but also in the long term in terms of the revenue impact that has on both the kind of system, and also but for our purposes for general practice as well. And I think lessons certainly that I've seen from the LIFT programme is making sure that you've got everything, you've got all the documentation in place at the outset, not moving straight into these centres without on the promise that things will be sorted out. We've seen a lot of practices that have come unstuck by moving without the full suite of documents being in place and clarity over charges in the future. So those are the sorts of things we probably need to, we certainly need to be looking at if these things take off with neighbourhood health centres.
I was just going to say, and where do you think the role is going to be with these multi-neighbourhood providers having a role with state strategy? Do you think that might give them more control, or potentially less control over how states are being used?
it's interesting. Well, so you were talking earlier about the estate strategy being kind of possibly delegated to these multi-neighbourhood providers, and I guess that there's a at the moment it sits at ICB level, and I guess it's a question of, well, who has the decision making over where services are delivered from, including existing surgery premises. So there is we do need to think carefully about how is that estate strategy going to be created, where's the who has influence over that strategy, and then how it's implemented. And so I think it comes back to the point of influence and being involved. And I think generally it's making sure that the estate that GPs already hold is being properly utilised. I think that's the other thing, and is coming up with good ways of making it work for the system. So I think those are but there is a shift there, which is something to watch.
Thank you. I think the other thing that we briefly mentioned when we've been discussing this is the potential risk to rent reimbursement. One of you want to just kind of expand on that one a bit?
Yeah, I mean, we don't know at the moment. The thing is, with currently we're all fairly familiar with the premises cost directions. Obviously, we had some new ones last year, which link into GMS contracts. So it's funding for GMS services. What the funding will be for premises under these new contracts is unknown at the moment. Will the premises cost directions apply to those new contracts? Will they be adjusted? My view is we probably will end up seeing a new set of premises cost directions to fit in with potentially with the new with the plans. So that's something to watch. I guess the other thing is how what are the new contracts going to look like in terms of duration? Are they going to be fixed term contracts? In which case, if you're signing up to a 5 or 10 year contract, that causes potential anxiety if on the other hand you're being asked to sign up to a 15 or 20 year lease. So there's things there that need to be thought through, and I guess we await the details of the new contracts. But I think the premises is a huge part of that, and we just we need to be making the point that those that needs to be considered, and hopefully it is, and it will be thought through in a way that doesn't create too much risk for GPs, but also doesn't it doesn't affect the market in terms of landlords being having the comfort of granting these leases, because part of the benefit for landlords of NHS estate is the security of the rental income over a duration of time, and if that is affected, it could affect the costs of builds and all sorts of things. So it's a complex arrangement that needs to be considered carefully.
Thanks, Bryn. There's just one other slide I wanted to mention. If move on, hang on a second. There we go. Just to bring people's attention before we go to questions with Ross. There is a neighbourhood health implementation programme that's being published. There's a link here, but it's available on NHS England's publications. This is designed at a place-wide level. So they're asking for PCNs across the entire place to come together with their other providers, social services, with other councils, all sorts of requirements. Just wanted to flag it with anybody who's on this call who may not be aware of it. If you're not, look on NHS England's website for it. Also, contact your ICB, because they're the ones who've got to support the applications, and they're by the 8th of August 2025. And this should be a way of kind of a supported programme from the centre to kickstart some of this development. There's not a huge amount of detail about it yet, but I'm sure your ICBs and mentioning will be able to help you. We just wanted to flag it for your attention just in case it was something you needed to jump on.
Somebody just asking there about pharmacy and dental. Why is there no mention of that? We haven't talked about it. We've been focusing on GPs, but there is references. There's about a page and a half about dental and its importance. And pharmacy is also mentioned as being very much part of the neighbourhoods. So they're not being ignored.
And a counter comment, I found a counter comment from Brian. I find myself asking more and more, would it be so bad for well-performing foundation trusts taking the primary care contract? Other than the perceived control the partnership model thinks it will lose, most GPs out there want to be doctors first and foremost. So a counter sort of there that it might not be such a bad thing. So anybody else, please, if you've got questions, you can come on, just click, take yourself off mute and just ask away if there is anything.
I did see one question about what if your PCN is not geographically aligned? Will you have to restructure? London, I think London-wide ICBs, I'm not sure exactly what their title is, they published a paper about 2 months ago in which they have expressly stated that where boundaries do not align, realignment to these footprints or development of local arrangements capable of operating efficiently and effectively across them will be required. So certainly it has been flagged in London that they might look, in fact will look, at breaking down some of the relationships and some of the PCNs to fit. That is obviously a fairly top-down model, and it's one that needs to be developed. We haven't seen that elsewhere, but it is certainly something to be aware of as a potential risk.
I'll just conclude by again reiterating that there's so many questions coming in, so we will try and circulate something that encapsulates all the questions and our answers to them. Thank you on behalf of my colleagues for attending. It's really appreciated. We'd also appreciate your feedback on the webinar and anything else that may be useful that you'd be interested in. Please don't hesitate to provide that, the link to the feedback showing here. Thank you again, and again, it's a brave new world, version number whatever we're in now, 52 of however many changes there have been, and we're there to help you try and navigate it. So please don't hesitate to contact any of us if you'd like to follow up discussions on this. Thank you all again. Goodbye.